Hi everyone, this is Dr. Rufus Vasanth Raj, Senior Consultant Orthopedic Surgeon, specialized in arthroscopy, trauma, joint replacement and sports medicine. Today's topic is about knee pain in elderly. So knee pain, what does it mean? We all know that knee is the most important joint for everybody to walk. So in elderly population, the word elderly in medical terms actually indicates people who are 65 plus. But any person more than 50 plus can come under this category also. So in my clinic, when I'm sitting, a patient comes, let's assume the patient's age is around 62, and they come and say, doctor, I have pain in knees. My first question is usually whether it's one knee or both the knees, because usually knee pains are bilateral. It's like a bike. Your bike has got two tires, so a body has got two knees. So these knees are the main things like the tires to walk around, move around for every purpose. So generally when a patient complains of pain, it's usually bilateral. If it's a bilateral pain, that is both the knees are involved, there are only two common diagnoses. One diagnosis is arthritis, the other diagnosis is osteoporosis. So arthritis, we all know, it's called as degenerative disease. It's again a simple comparison with the bike tire. As the tire runs for a long distance, it wears out. So people as they age, their knees can wear out, it is called as arthritis. The most common arthritis is osteoarthritis, which usually happens because of age. Of course, yes, there are other kinds of arthritis like psoriatic arthritis, rheumatoid arthritis and other multiple inflammatory conditions which can occur at younger population, but we are not discussing about that today. Our discussion is about elderly people with knee pain. So let's stick on to it. So elderly people with knee pain, commonly the main diagnosis is an arthritis. So the osteoarthritis usually happens on both the knees. If you look at the knee joint has got three compartments. Like how a train has got compartments, a knee has got three compartments. The inner aspect is called as a medial compartment. The outer aspect is called as a lateral compartment. And the third compartment is between your kneecap, that is a patella, and the thigh bone, that is a femur. It's called as a patellofemoral compartment. So out of these three compartments, the common compartment which is usually damaged as age comes is medial compartment, that is the inner side of the knee. So very classically, patients come and say, doctor, I have pain in both the knees, and both the knees is on the inner side. And inner side classically can be sometimes accompanied with bending of the knee. Commonly in elderly population, they can have a bent knee and their walking style might change. So this is very classical, and this is called as a varus deformity. The next common compartment is involved is the patellofemoral compartment, that is between the kneecap and the thigh bone. People classically complain that sitting and getting up is difficult, climbing steps is difficult, all because that's a movement. Because that's a place where the kneecap actually moves around the thigh bone, and most important part of the joint happens there. The last compartment to be involved is the lateral compartment, that is the outer aspect, which usually happens in rheumatoid arthritis and less commonly in osteoarthritis. So what we need to understand is that an elderly population, an elderly person coming to the clinic with knee pain, usually it's bilateral, and if it's bilateral and very commonly on the inner side and difficulty in climbing steps and all those things, we come to a diagnosis of arthritis. So what does the doctor do? The doctor first gets all the clear history. The history will be very classical. The patient will say, this pain is there for a long time. Let's assume that's there for 1 year, 2 years. It gradually progressed. And the patient will also say that for a near future, the last few days or few weeks, it's more painful. And then they also say that it's difficult to sit down, or sometimes easy to sit down but difficult to get up. They can also say that it's difficult to climb steps. So all these things are very classical symptoms given by the patient. The third thing which the patient usually says is that previously I used to walk a lot. Now my walking distance has come down. These are the clear symptoms of arthritis. The next thing are called as signs. That is what the doctor elicits. So the doctor will examine the patient. When I examine the patient, I look for a few things. I'll palpate the patient, I'll feel the patient's knee and see where the pain is. Usually it's on the inner side or on the top, sometimes on the outer side. The next thing what I look at is that, is the knee extending completely? That is the knee straightening out completely, or it is little bit bent? Bent in which direction? Inner side, outer side, behind, or whatever direction. So inner side is called as varus deformity, outer side is called as valgus deformity, and behind is called as a fixed flexion deformity. So all these three deformities are the ones which a doctor examines on the examination part. Now the doctor sees the patient's gait. Once the doctor is convinced that it might be an arthritis, the next step what we do is do an X-ray. The most important part of X-ray is that it has to be done on a standing position. Sometimes patients, they directly go to scan centers and come with X-rays. They might not be useful if they are done on a lying down position, because only when we stand, the entire body weight falls on the knee. When the entire body weight falls on the knee, the real kind of arthritis is seen because the joint space narrows. So what does a doctor see in a knee? The doctor normally sees the gap between the thigh bone and the leg bone, the gap between the thigh bone and the kneecap. If the gap is reduced, it's very classically called as arthritis. Then the doctor tries to grade the arthritis. So what are the grades of arthritis? Grade 1, which is more or less normal, the patient hardly has any symptoms and we can't find it on X-ray. Grade 2, the patient has got some mild symptoms which are not seen on X-ray but can be seen only on an MRI scan. Grade 3 is usually seen on X-ray itself, the joint space is reduced. In grade 4 arthritis, the joint space is completely reduced, the thigh bone is sitting on the leg bone, which is called as a bone-on-bone condition. In such conditions, the early stage is just bone-on-bone. In later stages, we start seeing deformities on the bone, depressions on the bone and the leg being bent. These are the things which a doctor sees on an X-ray. So now we have come to a conclusion which type of arthritis this is, and depending on the type of arthritis, the treatment changes. One common problem with most of the patients is that they assume that all arthritis needs a surgery. No, all arthritis doesn't need a surgery. Early stage of arthritis can be treated without surgical interventions. For example, anybody in stage 1 or stage 2, they just require some basic physiotherapy exercises. The concept of exercise is very simple. Once you strengthen your thigh muscles and calf muscles, the load falling on the knee is reduced. So automatically the muscles take up more load, the knee load is reduced and further progression of arthritis is stopped. The second thing is that we can give some collagen medications. Right now the recommendation is type 2 collagen around 40 milligram of tablet every day for at least 3 to 6 months. Once you take these kind of tablets, whatever mild arthritis which has started will slowly regrow and we can reverse the process in stage 1 and 2. Now when the patient comes in stage 3 arthritis, physiotherapy and tablets might not help to a great extreme. In such situations, we give injections inside the knee. The 3 common injections given inside the knee are steroids, hyaluronic acid that is called as a lubricant, and the third one is stem cell therapy. The commonly used one is PRP, platelet-rich plasma injection. Steroids are given for multiple reasons. According to me, steroids are usually given for only for one condition, an acute exacerbation of osteoarthritis. That is, the patient is having arthritis for a long time, but suddenly the patient has got an excruciating pain. So it's because of inflammation. One dose of steroid can help, but you can't repeat the doses often. Ideally, the next dose should not be repeated within 6 months. The other thing are lubricant injections. They have been in the market for quite some time. It's called as hyaluronic acid. A normal knee should have hyaluronic acid in a sufficient amount. It's a lubricant. It increases the viscosity. In arthritic cases, the content of hyaluronic acid comes down, so we artificially inject into the knee. The third thing is stem cell therapy, trying to reverse the process. In stage 3, all these things can be tried without an intervention. If the patient doesn't respond well, keyhole surgeries, arthroscopies can be done for the stage 3 arthritis. It is not a knee replacement, it's just a small incision. 2 small pricks are made, you go inside the joint. With the help of the camera, you look into the joint and then you start instrumentation. And whichever part is torn or whichever part the cartilage is worn out, we can try to regrow the cartilage by various techniques like microfracture chondroplasty, RF chondroplasty and multiple procedures. But once the patient reaches stage 4 arthritis, that is the bone has sat on the bone, that is the thigh bone is sitting on the leg bone, the only surgical option is the knee replacement. So we should never allow ourselves to go to that stage. The common mistake which patients do is that the early stage of arthritis, they don't come. They try to adapt. Sitting down is difficult, they stop sitting down. Climbing up steps is difficult, they stop climbing down. Then they convince themselves that they are feeling good, they are normal. Then slowly their walking comes on. Finally, when they come in the last stage of arthritis, not able to walk, the only option might be a surgical intervention. But if you come in the early stages, there are much better options and we can treat you without surgical intervention. So a knee pain elderly, the first common thing which I said is arthritis. The next common thing is called as osteoporosis. Osteoporosis is bone being weak. We especially see in postmenopausal women, the bones become weak. This can be tested by a DEXA scan or ultrasound guided BMD mission. These things will clearly indicate what level of osteoporosis or osteopenia you are. It just requires some supplement injections which can reverse the process. There are injections which increase the bone production like teriparatide. There are also injections which reduce the bone resorpting cells like denosumab injections. All these injections play a big role in the early stages of osteoporosis and osteopenia. So as a doctor, when I see an elderly patient with knee pain, it's bilateral. Usually when I see a patient with bilateral knee pain, there are only 2 common diagnoses. One is an osteoarthritis, that is degenerative disease. The other one is osteoporosis, where the bone becomes weak. But if again a patient comes to me saying that I have only pain in one knee, let's assume the patient has got pain only on the right knee, then there should be some other local cause. The X-ray might be looking normal, the patient might not give a clear history of injury, but sometimes on probing the patient will say, yes, when I sat down and got up, I heard a click sound in my knee. When I walked a lot yesterday for a function, I heard pain. I heard a sound in my knee, I had pain in my knee. All these are classical symptoms of meniscus being torn. So inside the knee, what I didn't explain before was that we also have something called as a shock absorber. This shock absorber is called as meniscus in medical term. Like how you have a shock absorber in a bike or car, God has also given you shock absorbers inside the knee. So these shock absorbers are called as meniscus. So what actually happens in elderly population when they strain a lot without even having a fall? So generally our assumption is that something has to be torn only when you have an injury. But elderly population need not have an injury, just a regular walk, a more strainful walk, some kind of injury like sitting and getting up or climbing steps a lot, they can have a meniscus injury. Sometimes it can be just a degenerative tear, but most of the times it can be a root tear. Root is something like how a tree has got a root. The main meniscus has got a main part called as root which can peel off. So in such situations, the only surgical option is, surgical option might be the only treatment. But we can of course, yes, try a lot of conservative therapy before going for a surgical intervention. So meniscus root repairs can be repaired with just minor keyhole surgeries. They don't need a knee replacement or big surgeries. So patients again ask, why should we do this surgery? My pain is minimal, but I'm suffering. We always say it's not just about the pain. Any pain, if you give some good painkillers and give physiotherapy, after some time the pain reduces, but it will not go. For the pain to completely go and for the patient to prevent any future degeneration like arthritis, the only option in meniscus root tears, it's surgical intervention. It's called as an arthroscopic meniscus root repair. It's a very straightforward procedure, guaranteed results. Patients do walk much earlier than a knee replacement and they do really well on these kind of procedures. To summarize, we understand that knee pain elderly, when it usually comes as both the knees, it can be an osteoarthritis or osteoporosis. But if it comes on only one knee, the most common diagnosis is meniscus root tear. Of course, yes, there are multiple problems inside the knee. You can have ligament tears, you can have other kind of issues like swellings, ganglion cysts and other things. But the most common one is usually a meniscus root tear, which can be treated. So overall, we have to understand that all these medical conditions in the knee can be properly treated and the patients can be made pain-free and get back to all normal activities, because as we age, the most important thing is mobilization. The moment your activity comes down, the knee pain is stopping you from moving. All these things will lead to other kinds of health issues like heart, diabetes not being controlled, hypertension not being controlled. So mobility is the key and this can be properly treated in any age group. We'll again meet up with some other interesting topic in the next episode. Thank you.